So, hi everybody, welcome, welcome, welcome. If you are not already on mute, I'll ask you to mute during our presentation. And then after the presentation, if we have enough time, we'll be able to certainly address any questions. So it is actually my pleasure to introduce my friend. And she just happens to be a neuropsychologist, Dr. Adrianna Zec, who she is from Henry Ford Hospital. She works in neuropsychology and actually worked with quite a few of our Parkinson's disease patients and movement disorders. So I am so looking forward to this presentation. I hope more people will join us because I feel it's so, so important. But without further delay, I would like to introduce Dr. Adrianna Zec.
Thank you so much. All right, well, thanks for having me, everybody. Julia asked me to spend some time kind of talking a little bit about neuropsych assessment, what we do and why we do it. And so I'll really just spend some time now kind of going over the basics and some of the fundamentals of why we do what we do and why I think it's a good idea for people to come in and see us and how it can be a benefit to folks, particularly those with Parkinson's and other movement concerns. And so we'll kind of review all that. And my screen's not moving forward. And as Julia mentioned, I'll certainly be talking. It's a little bit awkward on Zoom, so I won't be able to generally see people if they have something that they want to say, but please feel free if something's burning to interrupt me, and then definitely we'll have some time at the end to talk about any kind of questions or things that may come up. So some goals for today, just really kind of basically talking a little bit about what is neuropsychology. It's kind of a different appointment for folks and a different concept, so I'll run through some of that. Who are neuropsychologists? What do we do? What's our training? What you can expect in meeting with one. Talking a little bit more about neuropsychology and specific role in helping individuals with Parkinson's. The actual evaluation itself, what is it? What does it look like? Some of the benefits of going through the evaluation or the testing. And then, of course, as I mentioned, some hyper questions. So neuropsychology is sort of a branch of clinical psychology that studies how the brain and the nervous system sort of affect how we're able to function. It requires some knowledge about the brain or neuroanatomy and the functions that are sort of the output of these neuroanatomical or these brain-related kind of abilities and how they work together to allow us to do the things that we do or that we need to do. And also requires some various knowledge about general medicine, mental health concerns, and how they can impact functioning. So it's kind of a little bit of a hybrid of a lot of different things that allow us to kind of be in a special role to help people who are going through various difficulties that may impact their thinking or their functioning. Okay. So, this is typically done in concert with other information. So people typically come to see us and they have other things that their referring doctor may ask them to do in tandem with going through this evaluation. This can help us to sort of rule in or rule out other causes of changes in thinking. And this can be lab work that makes us, confident that the brain has different nutrients and minerals that it needs to kind of do what it has to do for us in a good way, and that it sets the brain up for sort of healthy functioning. Also things like structural scans, things that like MRIs or CT scans that look at sort of what is just the structure of the brain. And these different techniques are geared towards providing a picture of the brain and structurally what it looks like, again, to rule out other things that can cause thinking issues. But the tests that we run are designed to help look at sort of how the brain is functioning or how these systems are functioning. Okay. The major goal of all of this at the end of the day is really to just help to identify various thinking, cognitive strengths and weakness, and to apply those to what we know about how the brain kind of, again, functions or works for us. We do this in a very, kind of standardized way. So we use different assessments or methods to determine if there are changes that would suggest difficulties, again, or changes that can result from an injury, from various illnesses, sometimes just normal aging. And the way we go about seeing if those are changes is really using a lot of statistical and normative data. So I won't kind of go into the nuts and bolts of it, but basically this figure here is sort of the bell curve, the normal curve they call it. And the idea here is that if you measure enough things against across enough people, you'll sort of have this distribution of these abilities with the most kind of folks being in the average range, which is that large kind of shaded green area. And it's good to be average. Most people are average. So, 68% of people sort of are falling in these kind of ranges. And then there are areas on either side of that are sort of in the lower end of the average range or above average. And as you kind of fade off into the tails, some rarer scores or more kind of unusual scores, with those on the higher end suggesting, areas of significant strength or giftedness, and then some of those other areas suggesting real significant declines potentially. And this is all dependent on really understanding, where a person may or may not be, and we'll go into a little bit about how we kind of do that. But it's really based on these sort of standardized tests. So these tests are kind of developed with the knowledge that the brain is set up in a specific way for us, and it helps us to do things in most people who have a typical kind of developmental process and who typically are right-handed. Some caveats for left-handed individuals, but usually our brain's set up in a certain way, and it develops in a way where some areas are specialized to do certain things. So we know that in most people, the left side of our brain helps us to do things with verbal information, and kind of use things that we read or hear, to remember that information, to work with it. And the right side of our brain typically kind of does a lot of work with things that we see and sort of visual spatial information. And so based on these kind of this knowledge of these kind of different areas of specialization, we kind of set up a standard environment where we can measure these things. And so standardization really is kind of extends into test development, and then when we see people, how things look. So if people come in for testing, it's usually in a hopefully a quiet and calm environment, where you're working one-on-one with a person to really just kind of help to isolate these abilities or these kind of tasks. I say typically it's one-on-one because if people need help with interpretive services, then there's typically an interpreter that can be in the room, but otherwise it's just one-on-one with the person themselves and the person that is doing the testing. The instructions are standard, so everybody goes through the same set of instructions. All the tests are designed in a way where some are timed, some are not, and everybody goes through the same process. There's different scoring criteria that's also very standardized. Some of the new standardized things that are not typical are some COVID precautions that have obviously come about in the last few years. So if people come in, they can expect that they may be a little bit more distant. There's some physical separation between the person that they're working with, and of course, kind of wearing masks the whole time, which can be something to keep in mind as it is a longer appointment. So we always want to make sure that people are aware of that. Okay. So who are neuropsychologists? So we typically have obtained a doctoral degree, and that's either a PhD or a PsyD. And in addition to that doctoral degree in psychology, there's then specialized training in brain and behavior relationships. So typically a one-year residency or internship with specialized training in these brain behavior relationships, rounding with different areas of expertise. And then after that, a 2-year fellowship with more specialized training. Some folks are board certified, and that means that they've, 5 years into their practice, they've also gone through additional kind of stringent evaluations, and that's typically a 2 to 3 year process to get board certified. So you may see some of those kind of titles and names after people that you may see. And typically neuropsychologists are, some are in private practice, some are embedded in universities and hospitals, and they see people with various concerns. So learning difficulties, ADHD, those who have undergone, who have had a traumatic brain injury or stroke, concerns for Alzheimer's disease or other processes, people who may just experience normal aging, but may want to rule out other kind of concerns that may feel like it's not just sort of normal for age. People who are interested in surgical evaluations, people who may have conditions like epilepsy or for DBS for certain conditions, Parkinson's being one of them. And then Parkinson's disease itself, we often get referrals from movement disorders specialists to help with kind of some of the information we'll go into now, which is just, what can it help to answer and why do people typically come in to see us? Mhm. Typically, it's usually for one or more evaluations. So neuropsychologists are not generally folks that you're going to see day in and day out or week in and week out. They're usually called on board to help, identify issues or help provide some recommendations. And we can see people, once or twice in the kind of work up to that. And then maybe again, if a reevaluation is needed, and we'll certainly talk about kind of what reevaluation, when's that suggested or recommended. We're usually consulted by another discipline to kind of help out again. So typically from all kinds of other referral sources, neurology, primary care, psychiatry, and other disciplines to kind of help answer some questions. And a lot of those questions have to do with really just understanding a person's strengths and weaknesses cognitively, helping to kind of diagnose conditions, and then provide some recommendations for treatment or other things that may be of benefit to a person. Sometimes neuropsychologists do provide treatment. At Henry Ford, typically what we're providing is psychotherapy or cognitive remediation therapy to help address some issues. These are typically kind of time limited, 4 to 6 sessions to really kind of help people who are adjusting or who need some tweaking in terms of things that would be helpful to them in their everyday functioning when it comes to some cognitive or thinking changes, or if they're experiencing some kind of emotional or behavioral changes as a result of what they've been going through. And so there's kind of 2 roles for a neuropsychologist there. And then, of course, really communicating our findings to the people coming in to see us, as well as the referral sources, and help to make some suggestions about additional referrals or treatments that would be, of benefit to people. When it comes to Parkinson's disease, most everyone knows of Parkinson's as a motor disorder, a movement disorder. So the kind of prominent symptoms being those of movement. Those are the first symptoms that people notice, and those are the prominent symptoms that are typically the focus of treatment. But there can be some non-motor difficulties or changes that can come about because of Parkinson's. And those can include cognitive difficulties in some, but not necessarily all, as well as some changes in mood or behavior. Parkinson's can also impact sleep and the quality of a person's sleep, or the need for sleep, fatigue. That can also impact things like cognition or our mood, autonomic function. So things like orthostatic hypotension and some other things that can happen, as well as some sensory changes. So certainly, movement and motor problems are sort of the hallmark symptom, but we can have these other issues crop up, and that's typically when neuropsych testing or neuropsych consultation may be sought by people like neurology. So the neuropsych assessment itself kind of starts with a referral. And at Henry Ford, that typically has to come from a Henry Ford physician. And that's just the way they do it. But that may not be the case for other health systems, or if you have a private practice provider locally. But certainly there typically needs to be a referral. And it usually starts with an intake interview or sort of a consultation interview. And that can be done by oneself or sometimes with family. Sometimes family may notice changes that a person themselves may not know of, or they may have additional takes on things. And so it's always kind of useful to hear from folks in people's lives to understand, what their perception is of any changes or how they think that things would be, beneficial to address certain things. They can be done via video right now, and or they can be done in person. They could be done separately in person on a separate date, or they can be kind of rolled up into the actual date of the testing visit. It just makes for a little bit longer of a visit, but both can be done and both are routinely done. This typically lasts about 45 minutes to an hour. And it's really looking at getting an understanding of why people are coming to see us. Sometimes people themselves have concerns about changes in their thinking. Sometimes they just want, to get an assessment of where things are at. They haven't really seen any changes, but they want to get a baseline of how they're doing. Sometimes family has noticed changes that they haven't noticed. Sometimes doctors want these things done for various reasons. So we get a sense of, how people are perceiving what's going on for them, what their life looks like. Are they having any trouble doing things that they've always done? Are there things that are kind of new or that weren't there before? Are there longstanding issues that may have always been there, so that we can help kind of make sense of some of the data that we get? We also review a person's medical history with them, how they're feeling kind of emotionally, as well as some social history things. And so all of that takes about 45 minutes to an hour. Okay. These interviews are typically always covered by insurance, so that's the good thing. However, some insurance companies require prior authorization to go through with neuropsych testing. And so these intake interviews can also be, required by insurance companies. Insurance companies are funny beings. And so, I'm never really sure that there's a slam dunk that somebody who needs a pre-authorization will always get approved. But typically in folks who are coming from a specialist or who have a known condition that can affect thinking or the brain, they typically always get approved. And so that process takes another kind of couple of weeks by the time insurance will approve the testing or not. And their criteria is something called medical necessity, which is kind of broadly interpreted by whoever is reviewing the case. So some folks will need to go through a pre-authorization interview, and we kind of wait on that authorization and the insurance company's decision. Once all that's done, then a person can come in for the neuropsych testing. I wanted to add that in the course of testing, you may also meet with a psychometrician, and that is a master's level provider with training in the standard administration and scoring of the tests that we give. So these individuals can be standalone professionals or those who are on their way to becoming neuropsychologists, so our residents or fellows. And people will spend a lot of time with them typically because those are the folks that are going through the actual testing and administration with them. Sometimes a psychometrician may also be one of the neuropsychologists who does the testing as well as all of the other things. So that's another person that you may meet along the way. Okay. The assessment itself is really kind of paper and pencil and computerized testing. There's not a lot of physical activity involved. People are typically seated throughout the whole thing. There's certainly breaks that are encouraged throughout. People often have a question about how long the evaluation might be. Sometimes people believe it may be all day, and that's not typically the case. I think the range is between 2 to 4 or 5 hours of testing, and that all really depends on who the person is and what their concerns are. And so, for people who may be younger or people who are interested in things like accommodations for work or if they're taking tests or other things like that, those are typically longer days because some of those companies or institutions require a lot of different kind of tests be given to make sure that those accommodations can be afforded. And people who are a little bit older or who don't have those concerns and who just want a baseline, it's typically a shorter evaluation. It does depend on the person as well. Some people just take their time with things, and sometimes people work through at various paces. And so it's hard to estimate without someone getting started how long the actual testing day may be. But the person that you're working with will typically kind of keep you updated. It also depends on if you take breaks and lunch breaks, or smoke breaks, or whatever the case may be. The assessment really, again, we want people to just come in as best they can, kind of doing the things that they normally have done. So trying to sleep well, eat something, take all the medications as indicated. So there's no real restrictions or anything that a person shouldn't do before coming in. Taking medications that you normally take. There are certainly medications that people take maybe as needed for things like pain or sleep that can impact some of the testing, because those medications are also designed to just kind of quiet that central nervous system, and thus may make people a little bit less cognitively or sharp. And so certainly if people need that medication because they're in pain, we encourage them to take it. But if it's not sort of needed, not taking it immediately before testing, or at least letting us know if that's happened. Also encouraging people to bring whatever supportive equipment they may need. So certainly a lot of it is, back and forth questions and answers. So there's a requirement to certainly hear with the accuracy. And so if you use hearing aids, that's the time to bring them in and make sure they're charged up and working. Glasses to read different things that we may show you. All of those are important to have. And then anything else that you may need for comfort. So again, being aware that you're kind of seated throughout the day. We have typically good chairs, but people sometimes bring things to help support them, or if they need wrist brace or things like that, everyone's encouraged to bring those things that are kind of supportive. So that's the kind of part of the assessment leading up to, the testing. And I just wanted to review some of the things that I alluded to earlier in terms of some of the basics of the brain, and helping to understand why we are doing the testing that we're doing. So there's a very, very simplified version of things, but it's sort of a useful analogy to think about how the brain is set up, in that there are certain, areas that are very specific to abilities. So our ability to find the words for things, or call things by their name, are housed in a very specific area. Our ability to kind of retain information is also housed in a very specific area. And you can think of those as sort of the houses and buildings. These are, hardwired skills that live in certain places in the brain. But all of these kind of things that we do require a communication network to allow these areas to kind of learn new things and to communicate with one another. And that's run on a bunch of different transmitters and different connections in the brain. One of those connective kind of neurotransmitters is dopamine, which is, certainly one of the main causes of some of the movement related concerns in Parkinson's, but also because of the way it kind of helps the brain to send messages and communicate certain things, can also show up as leading to some cognitive problems for folks. And so when we think about some of the tests we use and how we measure things, kind of keeping this analogy in mind, that certain abilities live in certain areas in the brain, and certain things that we do require this transportation system to work so that things can be communicated in a specific way. And so when we see people for the cognitive testing, the neuropsych testing, we do sort of a comprehensive battery that looks at various skills. So we look at attention, processing speed, verbal or language abilities, our ability to use shapes and figures, visual spatial abilities. excuse me, something that you may have heard of, executive functioning. We call these higher order abilities. This is sort of the idea that there's kind of a CEO of the brain that really helps us to direct our attention, to think flexibly and organize and plan things. Um, our memory for things. So as we talked about before, memory requires, a certain storage mechanism that lives in a certain area, but it's also really dependent on a lot of steps along the way. And so in looking at memory, we're able to kind of break down some of those steps to see where kind of things may be breaking down for folks if they are experiencing memory trouble. And so tests of memory are part of certainly the battery, as well as motor and sensory functioning, and then asking some questions about how people are doing in terms of their mood or any changes in behavior, because that can also impact our thinking and how we're kind of processing information. Why the evaluation's a little bit on the longer side is that we don't want to just have one test for things and then kind of base any hypotheses or any judgments on kind of a blip on the radar. And so, it's normal for all of us to kind of have strengths and weaknesses that we've always had. And what we're kind of really looking at are any kind of patterns of performance that would be beyond just regular strengths and weaknesses. And so, when we do this testing and we kind of develop these tests, a lot of them are developed in people who have, no concerns at all. That's the typical kind of person that helps to develop these tests. And in those folks, it's very common to have some very low scores in an otherwise, good battery. And oftentimes that just reflects, again, just normal variability or things that may have gotten in the way on that particular task. And that's not a concern. It's more about sort of the pattern of performance. So all that is to say that sometimes people do get a little bit nervous sometimes that they may not do really well on one test, or that they may kind of spend a lot of time thinking about something they feel like they didn't do well on. And really, the tests are designed to be challenging. If they were really easy, it wouldn't really tell us much about where people are having challenges. And so it's quite normal for people to feel like some things they aced and did really well on, and some things were a struggle. That's kind of on purpose so that we can really make sure that we're kind of getting a range of people's abilities so that we can kind of help understand where the most kind of benefit would be from intervening in some of these more consistent weaknesses. So kind of back to those brain basics and thinking about some of the things that we kind of tend to think about with Parkinson's is some of the thinking changes that can be seen have to do with this role of how dopamine helps the brain to communicate and its connections with some of these areas that allow us to kind of think flexibly and organize sometimes information. And these are some things that do come up: multitasking and attention, the way that the brain allows us to kind of do all of that. But oftentimes that's also impacted by some situational factors that may not be just the role of dopamine itself. It may be kind of in addition to that, or on its own, causing people to have or experience thinking changes. A lot of those factors can be fatigue or sleep. So sometimes individuals with Parkinson's may experience that they get real tired real quickly. And that may impact their just general ability to kind of focus and give their all cognitively. Siri just started talking to me, so that's my Halloween spook for the moment. And so that can be something that we certainly keep in mind, and we like to highlight for people as something that may be a factor that's impacting them. Certainly medication effects, as we talked about earlier, so they can on their own just kind of suppress people's abilities if there are those things that are used to kind of quiet things like pain or anxiety or help promote sleep. But also sometimes because of that role of dopamine, people can experience benefits from their medication because it's helping to that communication network to work in a way that kind of feels more familiar, or more like they may feel like they used to be. Sometimes, having movements themselves can impact people, certainly during the testing. And so if people are experiencing things like dyskinesia or their tremor, that might impact something like asking people to kind of draw things or use their hands, just because they're more aware of it, or just the mechanics of it make it more of a challenge. And that can impact people's attention as well. And then, as we've talked about before, things like changes in mood. Those can come about because they've always been there. They can come about because people may be adjusting to difficulties that they haven't had to adjust to before. And sometimes the role of dopamine in regulating our mood and helping us to experience some of the things that we used to experience in terms of emotions and other things is changed. And that can also impact thinking as well. So in terms of kind of the evaluation, it's gone through all the evaluation, the testing is completed, and what can people expect after that? So typically, there's the result of all this is a rather lengthy report. It depends on the person doing it, but usually these can be from 4 to 20 pages, depending on who's writing it and how much testing was done or how much medical review there was. And there may be some weight on the results. So the results are typically not available that same day. And so sometimes if people are waiting to get the testing done so that they can coordinate for their next visit, it's something to keep in mind that there's usually about a 2 to 3 week lag time in kind of getting those results. And the report itself is just a combination of that intake or interview and reviewing things like history, the actual results themselves, what they mean and how they kind of reflect back on the brain or other things that could help to account for it. As well as the recommendations, which are sort of the more important part of the evaluation. Typically, most folks offer a feedback for people to have some time to have the results reviewed with them. This is certainly kind of optional. We offer it to everybody. And this is usually a 30 to 45-minute visit that can be virtual or in person to review the results, talk about the recommendations before that's communicated to the referring source. Okay. And so that typically is usually rolled into the first or to the entire charge. So people often have questions about, is that something that's covered or not? And that's usually all part of that, the whole evaluation is that feedback, though it is optional. Okay, so certainly thinking about some of the benefits or the goals of the evaluation, again, allowing us to kind of quantify cognitive strengths and weaknesses. It's an important thing to do. Typically when we encounter some difficulties or some things and we don't have a cause for them, we can just kind of slough it off to everyday type of things. If I forget where I parked, I'm not too concerned about it. But if I have something that people have told me may cause me to have some concerns about my thinking, that episode of me not remembering where I parked my car can maybe weigh on me and become a concern. And so neuropsych testing can help to say, are some of these kind of changes that people may be experiencing, are they normal for age? Because that's what we're really comparing folks to, is sort of people as much like them as possible. So are they just kind of anticipated or expected? Or do they, represent potential issues or concerns? And if they are there, these concerns, what are they due to? Are they related to some of the things we mentioned before that can impact thinking? Does the data kind of look like that? Or are there some other things that we need to either follow or be focused on, or help people to develop strategies to overcome some of these issues so that they can kind of feel like they're doing the things in the way they want to do them, and not kind of getting frustrated because of things kind of getting in the way of functioning. Additionally, as I mentioned, there's sort of can be a need for reevaluation to follow people. And we'll talk about how often that can happen or not. Um, and then sometimes, again, people may need accommodations for school or work because of thinking difficulties. We do this in people who have learning issues or ADHD, but we also do in people who may have some compromise in functioning because of health-related concerns or cognitive-related concerns. And these can be things like extra time to complete some tasks or extra supports for certain weaknesses that we may find. And so that can be kind of part of the outcome of the evaluation itself, um, as well as helping to, think about what strategies may be useful, um, and are there sort of additional providers that would be helpful. So again, some cognitive remediation therapy, psychotherapy, speech therapy. These things can also help to address some of the weaknesses that may be identified in the assessment itself. Okay. So, who and when should people come in for neuropsych testing? Obviously, it depends on people and how they're doing. If it was up to me, I think everyone should have a baseline of when they feel like they're doing pretty well with things. As I mentioned before, when we see people, we just really compare them to people who are as much like themselves and look at some tests that we know don't typically change because of illness or injury. We call those sort of hold tests that tend to let us know where a person may typically be in terms of that, average to lower average to higher average range. But when we don't have a baseline of people feeling like they're functioning fairly at the top of their game, then we're left with really just kind of comparing them to this group of people as much like them as possible. And so, from my perspective, I think people, should get a baseline assessment. That may not always be approved by insurance if it's just for a baseline, but if people again have a diagnosis, then typically I think the earlier the better to get that baseline done. Again, it helps us to really identify some potentially reversible causes of compromise or modifiable things, or really help to work with people on some things that we know are healthy for good cognitive aging, and some strategies that can really, not just address sort of weaknesses or compensate for things, but really work on what we call sort of neurogenesis, the idea that the brain can form new connections and kind of grow, and that act of doing those things can really help it stave off changes that come at it from normal aging and from other things that can make kind of thinking harder. And so that's also part of the evaluation too. In terms of the when, we can then sort of track changes for folks over time. We typically don't see people sooner than a year after seeing them because it's usually not enough. Before then is usually not enough time for the test to be meaningful again. Although that's not the case if something abrupt changes for people. So if they've had surgery or they've had, a change in their mental state or other injury, then we can certainly see individuals sooner. Getting that baseline is important too, because people may experience changes because of medication changes. And then that, having that baseline data really does help us to say, things are pretty stable or not. That can help to isolate, is this sort of Parkinson's changes, or is it the role of these other things like stressors or other medical issues that can compromise thinking? Again, medications that can compromise thinking. And all of this is in the sort of typical sense, but neuropsych also has sort of a special role in individuals who are interested in undergoing deep brain stimulation surgery. And so in that case, usually in most centers, or all centers that are approved to do it, a baseline is typically required. And so seeing a neuropsychologist is just part of the whole process. And it's the same process that I've outlined for you. It's just kind of built into the program, and that really helps us to get that baseline so that if people experience changes for the better, or if they feel like things have changed in the worse after surgery, then we have that baseline. We don't expect those changes to happen, but it allows us to really compare apples to apples in that situation. A neuropsychologist typically also sits on that surgical board to help inform surgical considerations and to talk with the treatment team about what things may be helpful, just before surgery, and then also putting in place some supports that can help to maximize the benefits people get from going through surgery, and kind of making sure that we're avoiding some maybe pitfalls of things if they're not paid attention to or missed. So overall, I think, obviously, I think that neuropsych assessment is useful in helping to understand people's kind of strengths and weaknesses, and really providing them with that information so that they can, have a sense of how things are going, and where, importantly, things may be useful in terms of helping any weaknesses by really using a lot of the strengths people have to offset those weaknesses, or working with them to develop strategies for things that are not coming as easily as they were before. It also may be helpful in identifying other factors that may be causing or compromising or exacerbating cognitive issues for people. It's useful to have that baseline to allow for some tracking of changes over time. And it really helps people understand that what may be kind of normal. Again, normal in quotes, but some changes do kind of normally come about as we age. And while they may be a difference for folks, there's a line at which it's expected difference, or an expected change, versus something that may be more difficult to kind of cope with. And so really helping to people to understand where they're at, and being able to give that assurance that maybe some changes are just to be as expected can be helpful. Yeah, some people find it fun, I promise. So, if you're interested in kind of brain games and things to kind of keep yourself cognitively busy, neuropsych testing is really good for that. And so it can be kind of an enjoyable experience. We also understand people who don't think it's an enjoyable experience, and really work to make it as enjoyable as possible, and kind of help them go through that. Okay. So those are sort of the kind of things that I wanted to be sure to cover with you all today and kind of highlight. But I certainly want to see if there's any questions or anything that I can help to address.
Thank you so much. That was fantastic, in my opinion. And I just want to tell people that you can use the chat box, or you can unmute yourself for questions. I just had one comment that I wanted to share beforehand. As most of you know, I worked at Henry Ford in the movement disorder clinic. And oftentimes when we would suggest neuropsych testing, people look like doe in headlamps. I think part of it is it's probably a horrible name for a test, because I think, oh, you're going to find something wrong with me. But I cannot stress the importance of baseline. Oh my gosh. Getting that baseline, I think, is so important, because we do see changes with the normal aging process, but also if there's sudden changes or things due to medication, plus the anxiety and depression that kind of goes hand in hand with Parkinson's disease. There's no reason to suffer or make this disease more unmanageable than what it has to be. So while everybody's different, it's such a boutique disease. There's these resources out here, and fear shouldn't stop you. That's me on my soapbox, and now I'll be quiet. So if anybody has questions, feel free to unmute or use the chat bar. see. You did such a good job.
I answered all questions.
I don't see anyone unmuting.
Yeah, and I don't think I can see the chat box that does.
Okay, can anyone hear me?
Oh, yes, yes, yes. Perfect.
You can hear me?
Yes.
Yes.
Thank you so much. I'm doing this from a phone. My name is Deborah Henry, and my husband is Warwick Henry, and he has Parkinson's. The question, and I came on a little late, but multitasking is what I have to do. My husband had a test which is similar to what you're speaking about, and we weren't prepared, and we're not prepared for it because we were told to go to the testing, and he had a medication reaction to some depression medication where it was increased, but it didn't work for him. So after this long testing that he went through, and he wasn't at his best for the reasons of he hadn't ate, we didn't know the test was going to be as long as it was, and he was just recovering from them having to flush the depression medication out of his system as it was explained to us. What would be the point of him to going back to having this test done again? What can he get from it to say, okay, let's say if your baseline is a 5, it's still a 5. Is there anything that can be given to where he's going to be a 6, a 5.5, or is it just to tell you, you're right, you're at a 5?
Well, I think, there's certainly no, rating. And usually it's, at least in the neuropsych testing, there can be some kind of rating systems when a neurologist may do a briefer battery. And so I'll leave that to my neurology colleagues. But, typically it's about the strengths and weaknesses and understanding if they're kind of consistent again with kind of normal aging or maybe some of those Parkinson's related changes that we would expect. Given that it sounds like it was, a pretty kind of stressful process at that time, that baseline may not have been accurate. And so if a person comes back and does testing and they're improved, then that can certainly say that, maybe that baseline wasn't accurate and that there are more strengths than were being appreciated then. And it would act as sort of a new baseline to, again, judge any kind of future changes against and kind of making new recommendations based on things that may have improved. Things are
okay. So if you have, and excuse me for interrupting. Okay, so you have a baseline. Now, once you have the baseline, what do you do?
So the baseline is used to again judge some changes over time. And so what we know about changes where in Parkinson's that may be progressive, if a person gets better over time, then it's likely not Parkinson's that's making that driving those changes. If a person is worsening, then certainly that may be a call for other interventions or medications potentially to kind of address the cause of that worsening. And so, I'm not sure in particular for your husband's case, but the baseline hopefully is accurate and allows us to track changes over time. If it's not accurate, then, it again will help us to at least say that it's better than before. And then we're not suspecting that this is sort of a progressive process.
And if I could just add one thing, I just wanted to mention too, is that I think it's important as well, and you may not agree with me, Dr. Zec, but how I feel is that I think it's important that when you go and have this neuropsych testing, that you ask the department or the scheduler if that tester or neuropsychologist has experience with Parkinson's disease, because as you all know, sometimes your medicines are, kicking in and then you're going off, and, it really can be a little bit of a roller coaster throughout that day. Well, centers that are familiar with psychologists that are working with Parkinson's, they know that, right? So I did want to add that as well.
Okay, and I'm not drawing a conclusion, but and I'm basing this on how my husband has responded to the speech therapist, the Big and Loud program for the third time. He says, once I have come here, I have done this exaggerating of raising the voice. He calls it hollering. He says, I've never hollered. I'm not in an environment where I'm required to holler, and it's just me and my wife, and we're talking. He says, so I'm gonna come here and do that, and then I go home and just do back what I've been doing, because that's what I do. So what his response was to the neurologist test was, okay, so you tested me, I went back for the review, and you just told me what I'm already doing. He didn't feel any benefit from it.
Yeah, and yeah, I'm not sure the exact circumstances. Hopefully people do come away with more kind of knowledge and some useful recommendations. And that's kind of sometimes things are done to kind of help a person understand where they're at. And again, those recommendations, sometimes people are sent to see us because the neurologist themselves just wants to better understand how things are going and where things may be headed. And so people may not feel this benefit in terms of how it directly impacts their daily lives. But it's something that helps to kind of make sure that people are aware of what are some of the supports that may be needed in helping people. So, if memory is a primary concern, do there need to be different kind of ways to interact with a person to make sure that they're following or able to follow certain recommendations? And so, certainly it's a case by case basis, and then, hopefully everything is useful to folks, but sometimes it may not be, or it may be part of what a neurologist's wish is in terms of helping them to figure out what to do next.
Okay. Okay, thank you for responding. I'll continue listening.
Let's see, I think we have a couple of chats, so let me just see here. The first one says, I was diagnosed on April 29th in Florida. I spend 6 months there every year. Lucky you on a day like today. Just saying, I'm ad-libbing. I have an appointment at U of M on May 2nd. Would it be appropriate to seek a baseline at that time, or should I pursue it this winter in Florida?
I think probably, the sooner the better, or where are you gonna be doing your care makes the most sense. So, oftentimes if your neurologist is at U of M, it might be nice to do it there so that they have access to that. There can be communication there. But if you're spending more time in Florida, or you can't get in by the time you leave, I don't think it would be harmful to do it in Florida, or it's going to be that much different to wait that long. But again, stressing, just the importance of making sure that you're, seeing somebody who does have some expertise in this. Again, usually somebody that's part of a medical center, somebody that's board certified is usually preferred, and making sure that they get a copy of that data so that you can bring it back to the people who follow you at them, or sign a release of information so that those people can continue. It's probably the most beneficial.
Good answer. But here's another really good question. Can neuropsychological testing help diagnose someone with Alzheimer's?
Yeah, so Alzheimer's is really, a disorder that is only definitively able to be diagnosed at autopsy, because people actually look at what are these are these plaques and tangles present in the brain matter. What we don't do that to people, because that's sort of not a great thing to do. And so what we do is kind of use various tests to rule things in or out. Neuropsych testing is part of that. And so what we know about Alzheimer's disease is that it tends to target certain areas of the brain first. And these areas of the brain control certain abilities, and those show up in certain ways on neuropsych testing. And so when we look at that profile of strengths and weaknesses, there is a kind of a profile that is concerning for Alzheimer's type changes. particularly if we're ruling other things out that can cause similar changes. So we make sure that the MRI doesn't show us anything that shows an abnormality in these areas that also govern these abilities. That again, that lab work is there, and the brain has the things that it needs to process. Another thing that can kind of masquerade sometimes as Alzheimer's is untreated sleep apnea. People are not getting enough oxygen throughout the night, and so that can really affect memory structures. And so it's a process of kind of ruling things in or out, but neuropsych testing is certainly helpful in saying that these changes are suspicious for Alzheimer's type changes, and therefore it makes sense to start treating them like Alzheimer's type changes by giving people medication that we know can help to slow changes down if that's what's causing it.
And I mean, I have to say that dementia, Alzheimer's, memory loss is such a complex topic, because not everybody falls into one category, and there's Parkinson's, dementia, Lewy body. I mean, there's so many different branches of dementia, and having seen notes from the neuropsych testing, I just have to share with you that yes, it's long, but it's comprehensive. And you spend maybe 20 minutes, maybe 30 minutes, if you're lucky, with the neurologist. You have the neuropsych's divided attention for several hours. So it is very comprehensive if anybody is on the fence. Very helpful.
And to answer that second question, yes, typically we have sort of profiles that are different for folks who are having, Parkinson's related cognitive decline that may be leading to Parkinson's dementia versus Alzheimer's related cognitive decline that may be kind of leading to Alzheimer's dementia. And so they look a little different on the testing, and that does help us to direct treatment. So some certain medications are indicated in Alzheimer's. They may be somewhat helpful if people are experiencing Parkinson's decline, but there may be others that are more helpful in either case. And so it helps us to work with neurology to think about what would be most beneficial to people.
And so beneficial to the family, I think, as well, to kind of know where we're landing or where we may be headed, or if it's a concern at all. Let's see, we have another question here. Let me just pull it up here. Would the diagnosis of Alzheimer's be significantly different than dementia associated with Parkinson's? So I think we answered that.
Yeah. For the medication question, I would really defer to your neurologist or the person that's helping. I don't prescribe medication, so I don't want to kind of step on anyone's toes or go outside of my bounds. But that's, we don't prescribe medication. We just talk about, based on our data, what could look like, and what are some things to consider. And the ultimate choice about what that looks like lies with the people who prescribe the medication. So,
yeah, and what people might not be aware of is that neurologists have like a dual board of psychiatry and neurology together. So oftentimes the neurologist is absolutely capable of recommending a medication and prescribing it. And sometimes maybe they want to refer you to a psychiatrist. So, it's not just a one answer for all, but a neurologist certainly can treat you for that. And I would recommend anybody that has Parkinson's that they should go to their neurologist first with that question.
Yeah.
Well, let's see. Well,
yeah, I just, if there's no other questions, I do want to just kind of again thank you. I think that a lot of the apprehension around neuropsych testing is, I understand it, but I think it may be just a part of, when somebody says you need to see a cardiologist, you immediately know what that might look like or why. A neuropsychologist, it's like, what is that? What is that going to look like? What am I going to be doing? And, hopefully this can put a face to the situation and as well as giving you like a little bit more of a background of what to expect, because sometimes the unexpected or the the unknown is scarier than the actual thing, or it causes people more nerves than they should. So certainly, I'm here as a resource if people have concerns or questions about neuropsych beyond today, but appreciate the opportunity to kind of talk to you about it.
Well, I'm going to be very respectful of your time, Dr. Zec, and I cannot thank you enough. I thought it was great. I don't see anybody asking any more questions, or everyone is still muted. And there's no other comments in the chat. So we will end up having this up on our YouTube channel. Our presentation, we recorded it so that you'll be able to refer back to it if you have other questions or you don't remember anything. But thank you very much for doing this. I think it was an important topic. And we'd love to have you back again sometime.
Well, you know my number.
I'll hunt you down. She knows that's
All
the truth. All right. Thank you so much.
Thank you very
Good
much.
night,
Take care,
everybody.
everyone. Good night.